Thank you so much, Jill, and thank you for putting this together. I mean, this is wonderful. Thank you for all of you for coming. It is my privilege to be part of this event. So thank you for organizing and counting with us. So um, this is my current team at Stanford. All we do is about teamwork. Remains critical in achieving the best outcomes. These are also the key part of our team that take care of you, of our patients. And I'm extremely grateful to the phenomenal work they do every day. I want to start with something a bit personal. This is the first time I met someone with acromegaly, that I learned about acromegaly. And this is my grandmother-in-law. And, when I started dating my wife, I'm still with her. I know after, since 1994. And she had acromegaly. And she went through it. She was in remission. She was treated by a top pituitary surgeon in Spain. And she was still struggling with some of the sequelae of that, but she lived a long life with some of the issues that you are all facing. After that, I went into medical school and I learned about acromegaly, and I became fascinated about pituitary, endocrinology, and surgery, brain surgery in general. So I started my training in neurosurgery. As you probably already know or guessed, I'm from Spain, Madrid, and a great country of science, culture, and history. And it was during my training as a neurosurgeon that I was heavily influenced by giants in the field that taught me that the most important knowledge as a surgeon, as a neurosurgeon, is the knowledge of the anatomy. And this is very obvious. It seems very obvious, but the reality is that it's not widely applied into training these days still. But something that fascinated me is something like this. This is an area of the brain that is deep, it's the cavern of sinus seen from an open approach. And this is a real operation, and you see how they look similar. This is in a specimen. This anatomical specimen is a human head that's been prepared in a special way so you can study it. So I became so fascinated about this, and I realized the importance of this, and I knew that some of the giants in the field had done that I had the unique opportunity to come to the United States to train. And I went with Professor Rotten, who is probably the most important neurosurgeon, American neurosurgeon in the second half of the century. He passed away a few years ago. He was the chairman at the University of Florida, where I went to study with him for 2 years. And this was 2 years after residency training, where I just spent those 2 years full-time in the laboratory setting, not seeing a single patient, just focus on doing this kind of work. This is some of my colleagues at that time. Most of them, I must confess, they were not Americans. They are all from out of the country. They are from Argentina, from Japan. Many Japanese would come. They would come to train and spend, 2 full years doing dissections in heads. Just like this is one of my Japanese colleagues doing dissections, learning the anatomy, the intricate anatomy of the inside of the brain, the base of the skull, etc. And again, this seems obvious, but this is not part of neurosurgical trainings these days. It is an option for whoever is interested, and very few are because they have other priorities for the most part, but this actually is the basis of becoming a better surgeon, understanding the anatomy really well, and developing this X-ray through vision, like Superman, looking through, you're able to see, because in surgery, you need to be able to anticipate what's going to happen on the other side of things. What is behind this part of the tumor before you see it, so you avoid getting in trouble because of that. So this is just an example of an operation. This is going from a transcranial approach, but you see this, when you do an operation that is highly complex like this, you have these steps that you've practiced in the laboratory, and all the roadmap to get deep into these areas of the brain or the skull base. And it is the best simulation you can ever do as a surgeon, in a human specimen. I guess in the near future, we'll have the ability to do this in a virtual reality environment, but we're still not there, and it has to develop much more. So, and this is the same with endonasal surgery. You can put the volume down. We don't need it. Thank you. And you see, this is working endonasally, and you see the anatomy This is an operation here, and this is the anatomy in the laboratory. It looks exactly the same. You see this nerve right here, this artery, the pituitary is up here. And, it is a way of, becoming much more comfortable doing complex operations. Also working in the laboratory, as they say, to achieve mastery in any craft, you need 10,000 hours, they say, maybe more, maybe less, I'm not sure, but you follow that, working 1 year in the laboratory gives you, maybe a quarter of that, 2 years give you half of that, and then you can start practicing and you get many more hours. So it's a way to shorten your path into mastery of a technique. Also, in addition to all the practice, we also, that time allowed me to contribute into academia, let's say, and this is Gray's Anatomy. I'm sure all of you knows about Gray's Anatomy. It's the most important textbook in medicine for anatomy, for teaching anatomy in medical schools. And I had the honor of writing the chapter or rewriting the chapter for Gray's Anatomy. Unfortunately, they did not get me for the other Gray's Anatomy. I tried, and I tried really hard, but just, I just got the other Gray's Anatomy. But so after that time in the laboratory, I started going into practice, and I went to University of Virginia in 2007, and I went for what we call clinical fellowships. Those are specialized trainings after residency training. And there I met especially this phenomenal giant of pituitary surgery, Dr. Ed Oldfield. He also passed away a few years ago, but he developed an amazing experience with Cushing's disease, which is, as you know, the other main functional disease in the pituitary. And he was using the microscope at that point, which, as you know, is a bit outdated technique these days, but he was using the microscope, and he was a real master. He had, 1,500 cases. That's unparalleled to anything with, but the second one is, 1,000 cases short of that. But not only the number of cases, but the quality of how he was doing them. And he described how some of these cases, rarely, but some of them could invade the middle wall of the cavernous sinus. And I saw him doing this technique a few times in my year there. And the difference is that if you actually remove the wall of the cavernous sinus along with the tumor that is invading it, you can cure that patient. And when you don't, the patient will not be cured. So that technique had a dramatic impact on the outcome of patients. Again, for patients with Cushing's disease. So after that, my time in Virginia, I went to the University of Pittsburgh. And this was, again, a unique opportunity because Pittsburgh at that point was the mecca of skull-base surgery, where endonasal skull-base surgery was being developed. And I joined the group of pioneers in the field, this group you see here. And again, for another 2 years of specialized clinical training there. And, during that time, that group was developing endonasal surgery. This is the technique where instead of microscope, you use an endoscope. An endoscope, is 4 millimeters in diameter. It's like a tube with a camera in the back, with a light source. And the beauty of this, you can put it inside, you can access so many areas of the skull base that the microscope does not allow you to access them. And not only that, it opens an avenue to the brain as opposed to certain areas of the brain, of the skulls of the brain, as opposed to going from above, you can go directly from below. And this has multiple benefits for certain lesions. Still, we need to do open approaches for many tumors or lesions, but for certain locations, the endonasal approach was proven to be definitely better, a better alternative, a better option. And absolutely for pituitary tumors. In pituitary tumors, then we translate from operating with a microscope to operating with the endoscope. And the difference is that the endoscope provides a much wider field of view. You can see so much more. The microscope gives you very high definition view, but it's very focal. But the endoscope allows you to see well beyond the borders of the pituitary gland. It basically allows you to see all, this is the pituitary gland. You can work in all these areas here that goes along the whole, what we call the ventral part of the skull base. So it really opened a complete new frontier for us as skull base surgeons. And my role during that time in Pittsburgh was, we were exploring a new field. We were seeing the anatomy from a different perspective, going to the nasal cavity with the endoscope. And because of my previous experience with Professor Rotten training in the lab, and I studied anatomy, we knew that we had to learn the anatomy again, or relearning from the endonasal perspective. And that is what we did. And this is the laboratory here with an endoscopic station, and this is in the OR. And we did the same studies that we did years before, but now applied to the endoscopic endonasal approach. And multiple studies have been published in the literature trying to describe new ways of doing things, new anatomy, new techniques. So many other surgeons can learn and benefit from our work. And I spent 10 years at the University of Pittsburgh, where with a team there, we did about 3,000 cases, personally about 1,000 of these endonasal skull-based cases. But we also taught so many courses, and we had people from all over the world coming to visit us and learn from us. And I also have a research program in the lab where I train, over 70 international fellows, so to spread the knowledge and the technique, all over worldwide. We also published our outcomes during that time. For example, this is our first paper on pituitary tumors, 555 cases, describe the outcomes, etc. And we, in 2018, what happened is Dr. Harsh, came to Pittsburgh for one of our courses, invited, and he was the pituitary surgeon here at Stanford, and skull-based and pituitary surgeon. And he approached me and he asked me if I would be interested in coming to Stanford too. He was going to be going to UC Davis to be the chairman there, and he wanted me to come to Stanford to consider that. And it really was a unique opportunity because there was no other surgeon with the type of training and expertise I had in the West Coast for the most part. And it worked out really well. So that's why I came to Stanford, because they offered me a unique opportunity. Right about that time, this company, Expertscapes, it ranks surgeons, physicians or doctors in general based on their contributions. It's an objective ranking on contributions based on publications. And they rank me, as you see here, #1 in the US Pacific zone for skull-based or skull-based tumors or skull-based surgery based on those publications. So they actually did a good recruitment. They were right about that. So then I came here to Stanford in the skull-based to run the skull-based center. So it was for me a great opportunity to come here, and I did really enjoyed my last 4 years here, working with great people like Dr. Cass Nelson. And my goal was to bring to Stanford surgical innovation, those we were developing at Pittsburgh. And I'm going to try to show you a bit of those innovations and what I think is changing the way we do pituitary surgery in general, but specifically for acromegaly and the outcomes we're having with these new techniques. As you've all heard about the cavernous sinus, probably, right? What is the cavernous sinus? You look at these cartoons, you heard Dr. Caneso before. This is the pituitary gland right here, right? The pituitary gland is enveloped in lining. This lining you see here is just like a bag, like an envelope. It's called dura, right? It's a meninges. And there is another envelope which goes wider. In between the two envelopes, there is a cavity, which is the cavernous sinus. This is a cavity with venous blood inside. It's like a pool of venous blood, like a collector of different veins. So the venous blood inside really is not relevant. You can just obliterate this one, and the nice thing is it's like a road. If you stop one road, the cars will find another way to get around. So it's the same with the venous blood in the brain. They'll find another way around. But this artery that runs inside the carotid artery, that is usually critical. Sometimes you can get by with the other one only, but usually you need both. So that's the key part that runs inside the cavernous sinus. And as you will see, also some of the nerves going to your eye muscles. So when tumors get into the cavernous sinus, things get more complicated because of its potential relationship to the carotid artery and the importance of that structures. Now, you look at this picture. This is probably the most detailed picture ever done, drawing of this area. I work with a medical illustrator that is so realistic to depict the accurate anatomy of this area. And this is based on our studies in the laboratory and also in surgical experience. But you see here, this is the pituitary gland right here. And this is the inner envelope. And then this is the outer envelope. There are two layers. that cover the pituitary gland, one that surrounds the pituitary gland completely, and the other one that goes over the carotid arteries to form that cavernous sinus. It's the bifurcation of these two layers of meninges here that forms that cavity of the cavernous sinus. Now, if you remove this anterior layer, what we call the anterior wall of the cavernous sinus here, this lining, this is what you see inside. So this is the cavernous sinus, basically, as you see it from an endonasal perspective. This is the carotid artery running here. And then this inner envelope, this we call this the medial wall of the cavernous sinus, because this is, the wall that is next separates the pituitary gland from the carotid artery. And it has these ligaments, these connections right here, which were not well described or studied before. But these ligaments, sort of anchor the pituitary gland or the line of the pituitary gland. So we name these ligaments. And we study the compartments. We see the bone behind this ligament, all these details here. There's a little artery here. I'm not going to go into detail because this is for surgeons, so much detail. But we learn all this so we could, really become comfortable working here. And the studying the anatomy makes you comfortable. You know what you're seeing, and you know what you're going to see behind, so you know what to do and how to deal with things inside. So we studied this. This is one of the dissections in the laboratory, for example. You see the carotid artery. This is the pituitary gland. We move the pituitary gland, things you can only do in the laboratory, of course. And then we move it out, and then we can see the lining here. This is the middle wall of the cavernous sinus right here. And why are we studying this so carefully? Because as you will see, tumors, and especially tumors that produce growth hormone, so often invade this lining right here. And it happened with Cushing's disease. The only thing is Cushing's disease is rare, but in acromegaly it's much more common. When tumors invade this wall of the cavernous sinus, you don't remove it, again, you are not in remission. And this removal really has improved the outcomes greatly. But in order to do this effectively and safely, we need to understand all the anatomy, all the details of this structure right here. So we studied in detail, we did cartoons. Doing cartoons is a good way to simplify your findings. And we found another ligament that runs here, the inferior one, we call it. Behind there is an artery. So you use like all these clues when you are doing an operation to prevent things from happening and to anticipate your next moves. You also need to study variations. Of course, every one of us, we have different eyes and different noses and different etc. But it's the same with anatomy. We all have a pituitary gland and carotid arteries, but we all have different configuration of the ligaments, for example. And understanding the variations when you are doing surgery is very important. So we studied those too. For example, a certain percentage of patients have this ligament, the other one has this other ligament. Understanding the variations to anticipate all possible scenarios when you're in surgery is also, greatly important. And therefore, we end up describing this technique, a step-by-step technique to remove the middle wall of the cavernous sinus. This original work, we got the NASBS is the North American Skull Base Society, and we got the award in 2018 for this contribution. And we also developed some tools, some techniques, some tools to apply these techniques. These are special dissectors and special knives that, for example, this knife has a blunt tip, so I can put it near the carotid but cut the ligament on top of it without risking, pinching the carotid. Things like that you develop to do your operations better. And also, tools that can be used by many other surgeons, and they can learn the techniques and they can use the tools also to apply this. And you can see this starts with some drawings and sketches that we do and different details on these instruments. So if you can please put the video, the voice. I'm going to show you this brief clip.
We can actually introduce instruments through each nostril. On one side, the endoscope, and on the other side, dissecting instruments such as micro scissors.
Brief
With the collaboration of our
approach.
ENT colleagues, we proceed with opening of the sphenoid sinus. This gives us access to the posterior wall of the sphenoid sinus, where we can identify the prominence of the pituitary gland, carotid arteries, cavernous sinus, and optic nerves.
So ENT colleagues
Here we can see the location of the endoscope inside the sphenoid sinus and the close-up view it provides. We use a high-speed drill to carefully remove the bone that covers the pituitary gland. We continue drilling laterally to perform a wide exposure into the anterior wall of the cavernous sinus on each side of the pituitary gland. We perform this XL technique where very thin bone is left behind so we can use a kerosene rainure to remove it safely and entirely. After the dura has been widely exposed, we perform or cruciate dural opening. We use micro scissors to open the dura in a cruciate fashion up to the level of the medial wall of the cavernous sinus. After widely opening the dura, we start identifying the difference between the pituitary gland, which looks well vascularized and more orange-like, from the pituitary tumor, which is less vascularized and more whitish or pale in appearance. By identifying this interface between both the pituitary gland and the tumor, we can develop an accurate plan of dissection to separate the tumor away from the pituitary gland. Whenever possible, we aim to perform an extracapsular dissection of the tumor to accurately separate it from the pituitary gland. In certain cases, tumors invade the medial wall of the cavernous sinus, and this poses a special challenge. For this, we have developed an original technique which consists in opening the anterior wall of the cavernous sinus to directly access the inside of the cavernous sinus and remove the medial wall. By directly opening the anterior wall of the cavernous sinus, we can identify the carotid artery in the cavernous sinus, the inferior hypophyseal artery running towards the posterior as well as the pituitary gland, and we can gently separate the medial wall that contains tumor from the cavernous carotid artery. The medial wall of the cavernous sinus can be removed en bloc by performing the disconnection of the carotidoclinidal ligament superiorly and the disconnection from the dural floor inferiorly. During this process, it is important to identify and typically coagulate and transect the inferior hypophyseal artery. At the end, we can achieve a complete tumor resection, including a complete removal of the medial wall of the cavernous sinus, which makes significant difference in patients' outcome, especially for functional pituitary tumors. As a conclusion, the endoscopic endonasal approach allows us to perform complete tumor removal with excellent preservation of the pituitary gland function, secondary to the superior visualization provided by the endoscope.
So that's a brief simulation we put together to simplify what we do and make it more understandable. But I've been doing this. Probably this is one of my first patients in Pittsburgh in 2014. This patient had a residual tumor, and after an operator, and there was tumor left on the wall of the cavernous sinus. And we removed the tumor, and he was then in remission. And then I started applying it at Stanford as soon as I came. This is another patient that we treated at that point. You can tell this patient had a tracheostomy. This is one of the most dramatic cases of acromegaly I've seen, because this patient was undiagnosed for so many years. His airway became so compromised that he did a tracheostomy without knowing he had acromegaly. Only years later, someone thought about doing an MRI and blood work, and they found he had a tumor that we operated and removed. And now he's finally got rid of his tracheostomy after all these years. What an extreme case. But I'm going to show you now how it looks in a real scenario. So if someone is sensitive to real surgical footage, please just let me know. I can stop or pass. But this is a small tumor. And one of the things that first we do that a lot of surgeons don't do is we expand the approach laterally to really expose the lining that covers the carotid artery. This is really safe. There is a membrane that covers the whole carotid. But you need to do that in order to access and expose the cavernous sinus. The second thing, you separate pituitary gland here. This is the normal gland from the tumor. And you always can tell what is gland and what is tumor based on how it looks, the consistency, the color, etc. Then in a case like this, remove the tumor entirely, but then you see those white implants. They are in the wall of the cavernous sinus, and they don't come out. So in the past, we would just burn them and hope for the best. But in this case, we just open the wall of the cavernous sinus. You get venous bleeding, but that is low pressure bleeding. It's very easy to stop it. Just we use some kind of paste as a hemostatic agent. Really very easy to stop the venous bleeding. And you see here we're dissecting. This membrane is the middle wall of the cavernous sinus. And this one is the anterior one. And the carotid is going to be running right here. So this medial wall and this anterior wall. So the tumor is in this medial wall right there. So now, because we learned the anatomy, we learned those ligaments, the attachments of that wall, we selectively go and we transect them. And we, step by step, separate this membrane. is, you have to remove this wall. You go to one corner, each corner, just gradually removing it until you can bring it completely out. You can see that implant of tumor going through the wall. In a case like this, it actually becomes quite simple because this tumor is not stuck to the carotid artery. It's just in the wall. It's well separated from the carotid. This is, quite straightforward at this point. In the past, it was a challenge, but now it really is not. What we do also, we send these samples to the pathologist, and they do analysis, of course, under the microscope to see there are tumor cells, to confirm that those are tumor cells in these walls. And then this is the histological studies they do. And you can see that that looks more purple. Those are tumor cells embedded in that fibrous tissue, which demonstrates that, the tumor was embedding there. We rely a lot of visual inspection in surgery. You really can tell very well. But we want to confirm with histology as much as possible. So that is one of those examples that is unique because there is a very small tumor that you would not expect to invade the cavernous sinus. However, it's invading. And if you don't remove it, that patient would not be in remission. So what we do with cases, you see, they have 3 different cases. This A and F, for example, here, they look the same size. This one is not invading the wall of the cavernous sinus. I look in surgery and it looks very clean. This one is actually invading the wall of the cavernous sinus, as you did here, and we confirm it. This one is grossly invading the cavernous sinus, and these are the tumors that are really challenging because they really are stuck to the carotid artery. And now, after years of experience, we learn how to safely detach these tumors from the carotid artery, but that's another level of effort and difficulty than the smaller tumors. So when we started doing this at Stanford, I like to obviously always review what are our results, what we're doing. Is it safe? That's the first thing. And these are first series of first 2 years at Stanford, about 120 cases of pituitary tumors. And the first thing we noticed is that more than half, we actually had to either remove the medial wall or go into the cavernous sinus. There are some pituitary tumors that not even once or almost or never go into the cavernous sinus because of the risk to injure the carotid artery. And you see, in my cases, in more than half, we were going to that cavernous sinus because we thought it was the right thing to do. And we did that safely. We didn't have a single injury to the carotid artery. And the main side effect we found doing these things, of course, I've been doing this in Pittsburgh for all those years before, but this is just the experience at Stanford, is that, 2 out of the 58 patients got transient double vision. Why is that happening? If we look at this is another one of our studies, at the anatomy of the area of the cavernous sinus, there is a nerve that is this thing going right here, behind the carotid, at the very bottom floor of this cavernous sinus cavity. This nerve is called the 6th cranial nerve. And it runs behind the carotid, and it runs like this, and it goes to the back of the eye, and then goes to the lateral rectus muscle, a muscle that moves your eye lateral. It's a nerve that goes to a single muscle. So this nerve is, as opposed to these other nerves, which are number 2 is the nerve for vision, 3 is the most important nerve for the eye muscles because it goes to 6 different muscles. So you injure this one, you can open your eye, you can barely move it. And then there is a V1, this nerve gives sensation to your cornea and to around the eye. All those nerves are on the lateral wall, so they are away. So you almost never damage those. It's very, very difficult to damage those nerves when you go through an endonasal approach. They are more susceptible for damage when you go from an open approach. So these are not the problem. But this one runs a bit more on its own on the floor of the cavernous sinus and is more free. So that is a bit more sensitive. And when we go here, we're at risk of injuring this nerve. And what we were seeing is that we are not injuring this nerve. But when we go in this area and we put some of the hemostatic material, some of that pressure might injure the nerve in a temporary basis. So only 2 of those patients got double vision. Both of them recover. But we also started looking at our results, and we were, very pleasantly surprised that our remission rates were on those first 23 patients, 91%. Just a reference, my own series of what we were doing in Pittsburgh, our remission rates were 51%. So that's a very significant jump and improvement in the remission rates. And all of our patients were, the few that were not in remission with surgery, were well controlled with medication. And that didn't happen before. There were 30% of patients that, even after surgery medication, they were still and not having good levels and having symptoms, etc., etc. So, really dramatic improvement in my own results. When we compare, then we kept increasing. We're now on 30 cases, and we went to 93% remission rate. If you compare with, this is a meta-analysis, that means they collect outcomes from multiple surgeons or centers across the country, across the world. And the average control rates were between 49 and 63%. So around that 50-60% is the number in general. And ours were, above 90% again. So showing significantly better results than, that ever reported before. We also found something really interesting, which is, I do all type of pituitary tumors, of course, and then we compare them, and we see that, of all the type of pituitary tumors we see here, you have a somatotroph tumor, a tumor that produces growth hormone. You're at 20. You have the odds ratio, which means you have 20 times more chances of invading the wall of the cavernous sinus than the other tumor types. So this is also new knowledge. This is something that was not known before. So with our technique, we're not only improving the results, but also getting new knowledge on how these tumors behave. So these tumors are more invasive than others. We'll get into why in a little bit. But we also learned that, when we classify pituitary tumors, we look at MRIs, and we see the size, but the extension of the tumor towards the cavernous sinus. And there is something called the NOSP grade. NOSP is a German neurosurgeon that described this years ago. And it goes from 0 to 4. Of course, the higher the grade, the more invasive it is to the cavernous sinus. But this is developed for all pituitary tumors across the board. And that's what we all use universally. So the expected invasion for NOSP grades is supposed to be 0%, 1%, 10%, 38%, 100%, from 0 to 4. But what we're seeing with patients with acromegaly, in this series, grade 1 was 29% as opposed to 0. Grade 1 was 57% as opposed to 1. Grade 2 was 100%, 100%, 100%, as opposed to what you see here. So a complete dramatic difference on how this universally used imaging indicator completely used different in acromegaly. So it actually becomes useless for acromegaly. Looking at the imaging you need to have a different interpretation. So when we look at imaging now in pituitary tumors that produce growth hormone and cause acromegaly, when I see a grade 2 and a grade 3, I know they're always going to be invading the cavernous sinus. When I see the small ones, I say, well, these ones, we'll see. It might be invading. We need to, if it's touching the wall, I know that I have to be diligent and explore the wall and see if it's invading it or not. So it really changes the way we do our strategy for treatment of these tumors. Now we keep collecting an experience and accumulating, and we keep reviewing our results. So this is the latest, not up to date, but up to 6 months ago or so, and 207 cases with still almost a half of them require going to the cavernous sinus, and we still are doing this very safely with no injuries to the carotid. And I must say, before coming to Stanford, in my 10 years in Pittsburgh, I didn't have a single injury to the carotid doing all these operations, or many others we do also around the carotid artery. And the reason is you just need to know the anatomy. You need to be extremely careful when I do these operations. I take as many hours I have to take, and I go as slow as I have to go. I can be very fast in some areas, but I have to get very slow when I'm working in the carotid, because I know that if I get distracted, things can happen. You need to be very focused on what you do to prevent these things from happening. We are looking at our remission rates are 95%. This across the board includes all tumor types. And the diplopia, the double vision rate still remains about very low, only 4%, and it's still transient. And when we look at also, the thing that is also remarkable on what we are learning now is cases that are recurrent or residual. These are cases where someone else had operated before and the tumor is either left behind, part of it, or is growing back. And we are doing more and more of these cases, and we collected 38 recent cases, and we are looking at the results on this. You see 11 out of the 12 were, for example, that were somatotroph, were in the cavernous sinus. And most of them were in the cavernous sinus when you're talking about recurrent cases. And what is remarkable, the Beckham remission rate in this one still remains very high. Not as high, because these are usually more difficult tumors. There is a scar that is from previous operation, but it still is at 84%. The risk of double vision is a bit higher, 13%, but it's still transient. So for being recurrent cases, these are still, I think, very good results. And we keep collecting, and our remission rates is still above 90%. We are, as we get more and more difficult cases, we have now one patient that is not in remission with medication, but is better, and we'll discuss what to do in those cases in a second. So tumors like this is one I did recently, this young girl from Ohio. So really large tumors. These tumors in the past were considered, for the most part, the chances of getting remission in a tumor like this, it was a co-secreting growth tumor and prolactinoma, is close to 0%. You ask, a pool of many surgeons' experience. They say this is so difficult to get remission in cases like this. And her post-op growth hormone level was 0.9, which equals like a 99% chance of long-term remission. We still have to wait for the IGF-1 levels because this is a recent case. But this is a very difficult case. I'm going to show you some of the footage of this case. This is a very invasive and aggressive histology also. This is a nice way of, this is the pituitary gland here. Very thin layer, even a very thin layer we can preserve, find it, find it where is the normal gland and push it to one side. We've removed the easy part of the tumor, which is all this, but now we need to go to the cavernous sinus. And in this case, there is a lot of tumor and it's completely stuck to the carotid artery. And this really becomes very difficult. You have to be, very careful doing this technique. This operation took me easily 6 hours to complete. And all these little attachments, I have to go one by one. You see those special instruments carrying them. You probably saw something called a Doppler ultrasound, where you can map the sound of the carotid artery, which gives you continuous localization of the carotid. But step by step, we can finally remove the whole tumor. And you see this is the whole carotid artery here, naked carotid artery here, completely preserved. And this is the normal pituitary gland, and the tumor is completely clean. And I'm optimistic this patient is going to be in remission in a very long term. Tumors like this, similarly, this is the highest grade of those NOS4 invading the cavernous sinus in all areas. And this patient took 6 months, but her IGF-1 became normal with no medication. Really extreme cases. We cannot cure with surgery all cases. I wish we could, but we can't. But this is an extreme case also. There's so much tumor invading here, in everywhere. But we did an operation and removed just a small portion of tumor right here. And that small portion of tumor now can be treated with radiation, focal radiation, or more focal radiation than you would need before for such a big tumor. And this patient now is in remission after surgery plus radiation. So if we focus on patients that had persistent acromegaly after surgery, and what the results are, the experience is growing, and of the last 12 patients we did, 10 are in remission only with surgery. And again, these are no significant complications from that surgery. For example, this patient here had this tumor in this area, and it does happen that these patients, they come to me and they ask me what, I've been told that I have no tumor in my MRI. And someone was asking before. So the first thing you want to make sure that someone that is experienced and knowledgeable look at the MRI to make sure that there's tumor or not. Because sometimes they say, this is not tumor, but there is tumor. This is very clearly tumor right here. She was told there is no tumor. Some specialists, but some others say there is, but it's impossible to remove. Let's do radiation. That's a valid option in this case. But the patient doesn't want to have radiation. We can talk about the reasons why in a minute, but one of the reasons is, this is close to the pituitary gland, and there is some risk of injuring the pituitary gland with radiation. And especially if you're a young woman, you want to have children, that's a consideration that is important. Although it can be treated with hormones, but you always want to be, in my opinion, leave radiation for the last option. So we did surgery, and this is, completely clean cavernous sinus, and she's normalized with no medication. This is a patient from New York, and she actually posted this in Twitter, and she said, I'll be forever grateful, etc., because I was the only one willing to do the operation. But the merit is hers for being brave and come to me to have surgery. That's what she wanted, and I told her, I think we can definitely do it. Otherwise, I wouldn't do it, and we did. It took me, long, 6-8 hours to complete her operation and remove it from there. But she's doing very well. This is the case of Jennifer, who is with us today from Alabama. Thank you for coming, Jennifer. It's so good to see you. And she had this tumor, difficult one. Sometimes tumors go into, the brain space has something called the arachnoid. That is like a web that protects the structures. And sometimes tumors can grow through that web, that arachnoid. And they did an operation which did a good job in the sense that they removed a lot of the tumor, but there was this bit of tumor here underneath the optic nerves, not really going to the cavernous sinus, but going into the stuck to the optic nerve. So not a good option for radiation, because the risk of injuring the optic nerve is high if the tumor is so stuck. And these were her levels and before medication. So this is going to surgery. Now we're going above the pituitary, towards the optic nerve. And this is the optic apparatus right here. Really the anatomy inside the brain is beautiful. You have beautiful optic nerves, Jennifer. You really do. And you see those little micro vessels. And here, this is the big carotid artery. And really the problem is injuring the tiny little vessels, because the carotid is very resistant. But the tiny little vessels, they are like just like a little hair. And they are difficult to preserve. And especially these tumors can be very invasive for those little vessels. So we were able to remove all the tumor, leave all these nice little vessels going to the optic apparatus, and get a complete resection with normal IgA1 levels. And I think doing well. Thank you. Thanks, Jennifer. Thank you so much. Amy from Illinois also came to have surgery with us at Stanford, and she knows she's smiling and happy after remove her residual tumor. And even patients from abroad. This is a patient from Israel, Mr. Barkan, who had an operation by a very experienced surgeon in Israel, and they left a lot of the tumor in the cavernous sinus. They thought it was not safe. And we face this in our profession. Sometimes surgeons say that tumor cannot be removed. Nobody can do it. It's impossible. And it happens more in the older generation. And a lot of these techniques are generational, in the sense that, the surgeons that are now in their 60s, for example, it's too late for them to learn these techniques. That's the way life works. It's my generation, and the ones that follow me will do better than I do to learn these new techniques and apply them. And they told him, this cannot be removed. But he insisted, he searched, he found us, he came to Stanford, removed the tumor, and he's also in complete remission. This is our operation. This tumor is wildly going to the cavernous sinus. You can see this is the tumor, all this gray thing, and then this is empty after removing the tumor. And this is the white thing is the tumor. The carotid is all this thing right here. It's stuck to the carotid, but this tumor, we were able to separate it, and not as difficult as others. This green thing you see is a dye we can put to see the carotid artery inside. It's like a contrast, and you can see in vivo where the carotid is. So we have all these tricks to see the carotid, hear the carotid. We use navigation also to see it in imaging. So we have all the possible safety measures to prevent injuring that carotid artery. And, because of these techniques, not just for acromegaly, but for many of the tumors in the pituitary, in the base of the skull, we've been treating patients for multiple places in the world coming to Stanford for treatment for these more innovative techniques. But not all histories are of success. There are many, but some of them are not as successful, but they still are successful to some extent. This is a patient from Chicago with a large tumor, very large. Sometimes, nature goes beyond our abilities, unfortunately. Perhaps in the future we'll be able to deal with it better, but this is such an invasive tumor. Did an operation, they remove all this. There was tumor left on the cavernous sinus, also above, and then Craig came to Stanford for surgery. He had all this tumor left, and they told him it's impossible to remove it. You require a craniotomy to go there. The nasal through the nose is not possible, etc. And I was not able to remove all the tumor. I removed most of it, but there was just this little bit here. left behind. However, his IgG1 levels at 6 weeks were normalized, but now at 6 months they are a bit higher than normal without medication. Probably if you go in medication, they'll normalize. He's feeling great clinically. So he's feeling so well, he doesn't want medication. But we'll have to discuss about that. But now he has the option perhaps of doing radiation only for this area. So even in cases where we cannot achieve a complete tumor resection, surgery is very often worthy because you diminish the amount of tumor to the minimal possible expression that can be treated with medication or with radiation. Because, radiation is very appealing because it's non-invasive. You don't need to go through an operation, and going through an operation is really hard. I mean, Jennifer can explain how hard it is to go through an operation, and it takes weeks, it takes months to recover from it, physically, and go back to your baseline. It really is not easy to go through that. But it's the most effective way. It's the most definitive way, but it's not easy. Surgery, radiation, on the other hand, is easier to go, especially if you go the 1 day or 2 day treatment, short radiation treatments. But still, there are side effects from that. The thing is, they are delayed. In surgery, when you go into surgery, you have the side effects right away, and in the following weeks. With radiation, it happens years after. And those side effects are related to your pituitary function. Often you get low hormones, and also your nerves can be decreased, especially your vision can be decreased, or some of those double vision nerves can be involved. So radiation has its merits, of course, but in my opinion, should be the last resort in treatment. And it has to be done in selected cases. In my series at Stanford, only 3% of the tumors, pituitary tumors we've sent for radiation. For acromegaly, only 2 out of 45 cases we've sent for radiation. So it has a role, but a very selective one. And I want to finish just showing something a bit more scientific, because one thing we've found with the latest results we've analyzed is that, maybe I don't know if you're familiar, but the pituitary tumors are now classified in a different way based on where they come from. There is supposed to be a stem cell in the pituitary these stem cells gives 3 lineages. And these 3 lineages are defined by these transcriptional factors. TPIT. Imagine like 3 families. You have the same grandpa with 3 different sons. These are the sons, right? So it's actually the PIT1 lineage which gives all these variants: somatotroph, somatolactotroph, lactotroph, thyrotroph, plurihormonal, all these 5 different variants, of which at least 3 can cause acromegaly. These are the variants we found that is the PIT1 lineage that actually defines the more invasiveness of these tumors. If you look at PIT1 with the other 2 families, and there is a 3rd family, probably an old one. The one, maybe this is the one that is the son that is out of the family, but there is the 4th one. Yes. So, but you see here, this is the incidence of cavernous sinus invasion, more than 50% versus these other families. So it's not just growth hormone adenomas, it's the tumors that come from that certain lineage genetically that are more invasive by nature, something that we are reporting now. But also, it's important to remember, this column here tells you that about 45%, with almost the majority of the tumors that invade the cavernous sinus, based on imaging, you would not expect those tumors to be invasive. Remember that classification we talked about before? They don't look overly invasive, but they are actually invading. So it's what we call microscopic invasion, and that's why we need to be so alert on these tumors, finding the potential invasiveness into the wall of the cavernous sinus. So to conclude, growth hormone adenomas, as you've seen, invade the middle wall of the cavernous sinus much more often than we previously knew, and it's actually driven by their genetic origin, the PIT1 family. When you remove the middle wall or the tumor into the cavernous sinus, the remission rates really increase dramatically to above 90%. And the results are good in terms of safety. The complications are low if you're experienced and you do it the right way. The problem is that, there are very few surgeons that are able to do this day, but we are working on training the next generation to do it. And more are going to be able to do it. And in a few years, this will be available in many more places with experience. When I teach surgeons these techniques, it's all about the carotid artery. That's what we worry about. So it's about understanding your enemy the best possible. Every ligament, every compartment, every segment, so you can remove tumor from it. And it feels, that quality is more important than quantity. You can find surgeons that, or there are many surgeons that have many thousands of pituitary tumor cases, but it's actually, the quality of the case you do, the results you have, not just the volume of the number of cases that really matters in tumors like this. And I always encourage, people that I train, be careful with being overly confident. The Dunning-Kruger effect, that when you are naive, you see someone doing something and you think immediately you can apply it and do it. And that actually is it can be very dangerous. It really takes a long time to build experience to become an expert to do these more advanced techniques. I like to do a similar, like going to Yosemite. And when I was visiting there, you see this little dot right there. And this is someone that is going up with ropes, trying to go Yosemite up, all the way up. Really risky. This is Alex Honnold, and I'm sure many of you know about him. He's the one that did this free solo all the way up, Capitan. And he would say, the reason I spent so much time preparing is because it was so scary. And for me, it was the same. It was scary to work around the carotid artery. And you need to prepare for that. It's the only way to be able to do it. But with enough preparation, it wasn't scary anymore. I knew I could do it. So when I saw him, I pretty much feel the same way. It is about the what you learn and the preparation that you put on to achieve what it seemed to be impossible or very difficult before. But you need to be respectful of the time it takes to build experience, because otherwise you're gonna have a big fall like from Yosemite. So thank you very much for having me. Thank you. I think we have a few minutes for questions before going to the breakout sessions, which we don't want to miss.
We have our microphone. If anyone wants to ask questions. World-renowned surgeon. Come on up.
Hello.
Hi.
Would you ever consider taking out a residual tumor that's still macroadenoma that is dead and just sitting there?
Well, if it's not functioning and not causing problems, no.
Just leave it.
Just leave it.
Okay.
If that patient has no symptoms, no acromegaly or no, why? No, I wouldn't.
How many surgeons are there now that do this type of operation?
That is a very difficult question.
Try.
If you phrase it differently, if you ask me, who would I send a patient to do this operation other than me? I would say there is another surgeon I would send it, who is in Pittsburgh. He worked with me for all these years, Dr. Paul Garner. I would send. I think he's a very good surgeon. He can do this very well. Thank you.
I have one question.
There could be more. We train some others. They are doing it. I think they're doing it well. They are less experienced, but they are building the experience and they are getting there. But I have to say to one, I would choose that one. But there are others that are doing it. There will be more very soon.
Hi. So if you had a patient that had already had that transpenoidal surgery twice and gamma knife surgery, and the gamma knife was to stop the invasion in the left cavernous sinus, would you consider your surgery to remove the residual?
Is the patient still symptomatic or having active persistent acromegaly?
The patient is under biochemical control.
I think if the patient is under, I would discuss with the patient and the endocrinologist if they are relatively happy with how the disease is controlled. No, I would continue with medication.
Okay, thank
now,
you.
if you struggle with medication, patient struggles with medication, significant side effects, increasing medication. If the endocrinologist is worried, Dr. Casnelson tells me, Juan, I think this patient, I'm having difficulty with this patient, then I would consider surgery.
Okay. And if it's a PIT 1, would there be a chance of the tumor continuing? I mean, even with Gamma Knife, would there be a chance for that patient to possibly have more growth?
You asked the question, I have to answer yes, it's possible.
Okay.
But it's unlikely. I think if the patient got radiosurgery, maybe the tumor will be under control.
Okay, thank you.
Thanks.
So I'm curious about microscopic cells. I guess the question would be is, can you go off the medication and allow the cells to grow to have a second surgery, or would you stay on the medication and just deal with the microscopic cells?
I think that would depend on whether the MRI shows, tumor, a target to go after. For me as a surgeon, I rely very much on imaging. I need to see the target in an MRI. I need to see what I'm going after. If I don't see it in an MRI, I cannot remove it. I have to see it. So if I see the tumor, stopping medication is not really relevant.
Okay,
It has implications on the post-operative testing, but not in the surgery itself. If you don't see the tumor and you still have active acromegaly, stopping the medication could make the tumor show up, possibly, but that's a very, very rare scenario.
Okay, thank you.
Anything else? Okay,
Thanks so much for being here with us.
Thank you.
This is very informative. You may have kind of already answered this question, but are there ever instances when you do surgical exploration of the pituitary gland when a patient is showing some symptoms of acromegaly, like elevated IGF, doesn't show an ectopic source?
So a negative MRI on acromegaly is rare, actually very rare. It happens more often in Cushing's disease. In acromegaly, it's very rare, but it can happen. Yes, I would consider if all the evidence points towards a pituitary source, and if medication is working really well, maybe in that case I would consider continuing on medication. But if medication is not working well, side effects, etc., I would consider exploring the gland. Yes.
And what sort of treatment outcomes have you seen with patients where you've done surgical exploration?
This is a very rare eventuality. I think my personal experience with this in acromegaly is very small. So I don't think I could give you an accurate estimation. Yeah, I could in Cushing's disease. That's a different thing. In Cushing's is about, those patients that you do not see a clear tumor in the MRI. The remission rate goes from being close to 100%, 98% to maybe being 80 to 85%.
Okay. And I may be mistaken, but I thought that I had read somewhere that your team reviews cases. Like if someone shares their imaging with Stanford, you'll review their case.
Absolutely. So as in this conference, we're not supposed to directly talk about your personal case, which I understand, of course. Any patient that want to consult with us, we're happy to do so. All we need is to get imaging and some brief medical records, especially laboratory testing, and we'll do so gladly.
Okay.
You can contact me and I'll help you with that.
Okay, great. Great, thank you.
Thank you.
As you are working on the forefront of surgery, whether it's endoscopic or radiosurgery, what do you see is maybe something that's not possible now, but is coming down the pipe, in 10 years or something? Do you see any treatments that people are working on that just aren't ready yet, but will be promising?
You're not talking about medications, but or you are. I think the main advance will happen in the medication field, personally. And I really hope that there are new drugs that are developed that can, melt these tumors away and get a cure of these tumors with just medication. That would be in the best interest of patients, of course. In terms of surgical progression, we still have room for improvement. I mean, we've evolved in the last decade, so we definitely can evolve in the next one. And radiation techniques are also getting better, with more intense radiation in more focal points, with less side effects. So yeah, things are going to get better.
Thank you.
Is there if you had a patient who had been told that they had a sticky tumor around the parotid, is that still something that surgery that you could take? I mean, is a sticky one even possible?
Yeah, it is.
Have the operation.
It is. Some of those tumors I showed or we operated, they're sticky. They are actually, growth melanomas are often sticky when they are in the cavernous sinus. It's interesting because often the tumor that is in the cella, in the center, near the pituitary gland, often is softer, but once they go into the cavernous sinus, they become more fibrous. So yes, we can remove the sticky ones too. They are more difficult, and it's not 100% we can remove them, but we definitely have. Yeah.
Awesome. Thank you.
Can I ask a question, Juan?
Yes, of course.
As you have outlined the detailed anatomy where you have the different ligaments and ligamentous structures and whatnot, and do you find that there is a pattern in pituitary dysfunction, hypofunction, I guess, after surgery based on what ligaments you're manipulating? So if your tumor is, let's say, more left-sided, right-sided, and the functioning tumor is...
Yeah. Something that more than the ligament, something that we studied and we published about is, maybe you saw that there's a little artery that is called the inferior hypophyseal artery. That it's a small branch that goes to the posterior part of the pituitary gland. And when we were doing these approaches, years ago, that artery is in our way, and you make it bleed. You can make it bleed from the wall of the carotid. It can be a bit troublesome. So the safest thing to do is to coagulate the artery and cut it, so you don't have a hole in the carotid itself. But we were wondering years ago, what happens if we coagulate this artery? Is the pituitary gland going to be affected because of this? And it turns out it's not. Even in cases where we coagulate on both sides, not for pituitary tumors, but there is another type of tumors we do that invade both cavernous sinus, something called chordomas for the most part, that we have to take both arteries, and the rate of pituitary dysfunction was very, very low. Usually pituitary dysfunction correlates more with tumor size. The bigger the tumor is, the more smashed the gland is, and the more the risk of not working well. Thank you. Thank you so much.